presentation will come up.
Yeah. Click on the right.
It should come up.
Will it come up? Thank you. Thank you for the invitation to speak. I'm sure we'll discuss the relapse refractory case, but you know, with cases like this that move so fast through all their lines, you wonder if there's something at the beginning that will tell us that actually they just need a bispecific antibody, but we probably talk about that later. So I've been asked to talk about the aims of induction therapy in fit myeloma patients, and here are my disclosures. So this is fairly obvious to all. What we want to do is to maximize disease-free survival and minimize treatment burden. I'm going to talk about the whole of frontline treatment as a pathway and not just induction regimens, but we do have highly effective induction regimens, and the longest PFS reported now is greater than 18 months, so it's going on 7 years with Cassiopeia and Perseus, I think, more or less equivalent, really, just 82, 84 months determination, which is the VRD ASCT arm, followed by Len maintenance at 68 months. But there are unanswered questions, and we can do better. So there's no room really for complacency, because if we think what we know about myeloma, of the disease heterogeneity, we're still giving the same treatment for all patients. And we need to think, what is the cost to the payers, to the patients? Is the benefit that we've seen over the years evident in all patients? And are we meeting patient goals? I'm conscious we haven't talked maybe at all about what patients want. We haven't asked patients. And increasingly, I think we need to. And so we've talked about this through the day already, about how we individualize and tailor therapy. So I think I'll continue on this theme. And I hope I'll be able to cover a little bit about CD38 antibody. Does one size fit all? When should we use it? I will come back to ASCT. Does everybody need an upfront ASCT? And maintenance. Is maintenance really treatment until progression? We've talked already about risk-adapted therapy and high-risk therapy. And I thought I might just touch on the future immune therapies, although I expect Matt will do much more about that. So starting with Cassiopeia, this is the study that provided the evidence for which we use Dara-VTD as standard of care in newly diagnosed fit patients today. And just to remind you that there are 2 randomization points. So R1 to randomize patients to Dara-VTD or VTD, and then there is a second, and there is always consolidation after the transplant, and then a second randomization to Dara or observation only. And you'll know this data, so I'll go through this quickly. There is a PFS benefit, and so this is the PFS I was referring to in the Dara-VTD arm, 83.7 months compared to VTD, and also an overall survival benefit at 72 months, 86% for Dara-VTD versus 77.7% for VTD. So quite clearly a benefit of daratumumab. I don't have time to go through the forest plots and subgroup analysis, but I think I'm right in saying that the CD38 antibody benefit is not quite so clear in high-risk patients. But what I did want to go on to talk about is the second randomization, which is the benefit of daratumumab. So here, because there were 2 randomizations, there are in fact 4 groups of patients. The first group who received Dara-VTD followed by Dara maintenance. The second group had Dara-VTD followed by observation only. And then the third group who received VTD followed by Dara maintenance, and then the fourth group, VTD, followed by nothing. And you can see clearly with the PFS curves here that the worst performing group are the ones that receive VTD and then nothing else after transplant. You might expect that. But interestingly, and possibly surprisingly at the time, the other 3 groups run very closely together. So you might think from this that perhaps it doesn't really matter when you get your CD38 antibody, either as part of induction or in maintenance. And this is probably backed up if you look at the CR-MRD negative rate. Now, you heard earlier today that today when we talk about MRD negativity, we really have to talk about it in the context of of a serological CR as well. And you can see the two groups of patients here and here, the ones who got dara-VTD and then observation, and VTD and then daratumumab maintenance, have very equivalent levels of deep response. And I make this point because it's come up again and again, and because the standard of care has daratumumab with VTD as induction therapy, and in RADAR, the standard risk patients only get our Cybody without isatuximab, without a CD38 antibody. But in fact, if they achieve MRD negativity, they do get a 38 antibody in maintenance post-ASCT, and if they're MRD positive, half of them will receive a CD38 antibody. And I do have some lab data to show you the effect of the antibody on immune function subsets. And of course, if they're high risk, they will receive, this is the new high-risk protocol 7. We've just registered our first patient today, which is very exciting. So for the high-risk patients, they will get a CD38 antibody throughout the treatment, continuing with doublet maintenance until progression. So talking about risk-adapted therapy and high-risk trials, you've heard already about the Optimum study, so I don't need to talk to you about that, but just to make the point that really for whom we understand today to be ultra-high-risk patients, we need to continue the therapeutic pressure on disease, and that is by using multi-agent induction followed by prolonged multi-agent consolidation and then maintenance. And whether you include a proteasome inhibitor in maintenance or not is unclear, but in the concept study they did. So this is the PFS for Optimum with the myeloma 11 as a comparator, showing a clear benefit, and the same general results are seen in the GMMG concept study, which also had prolonged consolidation and maintenance. And interesting, in the GMMG concept study, they continued the proteasome inhibitor together with the IMiD and the CD38 antibody. And this is, the investigators feel this is the important ingredient responsible for the improved, very good outcomes. This is the current study, which is the IFM study. Now, this is a high-risk protocol as well. I thought I'd show it to you. And here you can see the inclusion criteria, which are basically based on high-risk genetics. And here, again, a CD38 antibody with carfilzomib, which some people feel is warranted in the context of high-risk disease. 2 transplants, but interestingly and unusually interspaced in between with a consolidation block. And when I asked them why they did this, it was felt that to take patients from one to the second transplant was too quick, and that many patients hadn't recovered sufficiently from the transplant 1 to go on to the second, and this might lead to an undue number of early relapses. So bringing in the consolidation to deepen response and also bridge to the second transplant. And we wait, I think there's some early data on very good responses. So moving on to come back to the benefit of frontline ASCT and whether one size fits all. Now, I don't have time to go through all the randomized studies that we've seen, but okay. So when we evaluate or we think about assessing the benefit of frontline ASCT, it's important to bear in mind what the alternative is. Now, it's important to remember that in all the randomized studies, the non-ASCT arm got the same maintenance. But if we today were to allocate a patient who'd achieved a very good response and didn't really want to go onto a second transplant, onto a transplant, if they stopped treatment or continued on chemo, they would not get maintenance, and that's the difference. And of course, critically, the efficacy of salvage. So all these other factors come into play when you're considering the benefit of an upfront ASCT and when you talk to your patients. So this is the paired studies with IFM study on the left and the determination study on the right, but both studies have the same design with VRD, 3 cycles of VRD, a transplant, and then 2 cycles of VRD in one arm, but in the second arm, in arm B, 5 cycles of VRD instead of the transplant and the consolidation. And everybody gets Len maintenance. And here you can see a clear benefit for people who got the ASCT arm in red. But the key difference between these two studies, of course, is that in determination, Len maintenance was until progression, whereas in the IFM study, only 1 year of Len maintenance. You've seen the IFM data already stratified by PFS in the MRD session, and you can see a big difference in the median PFS, but no difference in overall survival. So we don't have any evidence for a survival benefit for using frontline ASCT. There's also a big difference, so as I said earlier on, the outcomes depend on what people get at relapse or what is available. And in the determination study, with such a long PFS, only 28% of the relapse patients receive salvage ASCT. And so if you look at the outcome by MRD status, and this is data you will have seen and probably know already, if you're MRD negative, the benefit of having received a transplant doesn't seem so clear, whereas if you're MRD positive, distinction between these two arms, the transplant and the non-transplant arm, is more obvious. And we had the same answer in the Cardamom study, although it's only a phase 2, a significant benefit for MRD positive, but not MRD negative patients. And in the Cardamom study, what we were able to do was to look at MRD status after induction, so pre-transplant. And so these studies have led most investigators in the field who are still interested in looking at the benefit of frontline transplant to stratify according to MRD and to ask the question. This is the MIDAS study, and you might have seen this already this morning, in which patients receive ESA KRD. So ESA KRD is a kind of a quad, a favorite quad, with a CD38 antibody, an effective PI, 4 drug regimens, 6 cycles, so quite a lot of quite intensive induction. And then people who are MRD negative then get assigned a standard risk group, which is rather confusing nomenclature, but you can see that they get randomized to have a transplant and consolidation or continue with ESA KRD, whereas the people who are MRD positive are labeled high risk, and they are assigned to either have 2 transplants or 1 transplant and 2 cycles of ESA KRD. And then for the high risk MRD positive people, they get to receive isatuximab plus iberdomide. So really quite intensive treatment, and whereas the MRD negative people get lenalidomide standard of care. So I've put this up to show you this is what the rest of the world, or the world, is thinking about in terms of how we address the question about the benefit of frontline ASCT in newly diagnosed fit patients. And then, of course, an alternative to ASCT, as you will have heard the debates already, might be CAR T cells, and this is the CARTITUDE-6 EMN study that randomizes patients to have cilta-cel or an ASCT, and the cilta-cel arm is followed by both arms have our maintenance. I think it's for 2 years, but the ASCT arm has 2 cycles of DVRD as consolidation, and I think that's open in some centers here. And I think we will go on to have these studies addressing the role of ASCT, because although it's standard of care, and it's standard of care here and in many countries in Europe, there is still the feeling that it's not the optimal treatment path for everyone, and that there is a way of trying to unpick the complexity and understand which particular patients benefit and don't. And for example, the determination study, those of you who have seen the presentations will know that the benefit of ASCT is not seen in the African Americans. And you can see here, I've just shown you the forest plot. So with the Afro-Americans on this side and the white patients on this side, the forest plot in the middle, and the green bars refer to the Afro-Americans and the blue to the white patients. You will see here that if you look at all the patients, all the AA patients, there is equipoise here between transplant and no transplant. However, if you break them down by BMI, you can see that this equipoise splits according to BMI. This is a very crude way of looking at it. There's there's a great deal of interest in looking at, for example, a Duffy red cell group and other parameters. But suffice to say that this sort of, a large study like this allows us to unpick and look at specific factors and perhaps learn how to stratify treatment and in a way towards personalized therapy. So to move on, what are the key questions in maintenance? Clearly, how long should we give it for? Are there newer agents and regimens? And we've already heard about risk-adapted approaches. So I think Kartik has shown you the master study, the dramatic study. So I shan't show you this, but this was alluded to by Roger. So what Charlotte has done in this analysis is to look at the people who received Len maintenance in myeloma 11 versus those who on the observation arm, and for MRD negative and MRD positive patients separately, evaluate and assess the benefit of ongoing Len maintenance at each time point based on what their MRD status was. So landmark analysis. Charlotte's sitting there so she can correct me if I'm wrong, which is very, very fortunate indeed. So for example, here for the MRD negative group are on the top line. And here the benefit of continuing to receive Len maintenance, if you are still MRD negative at 2 years, 3 years, 4 years, and 5 years, is what these curves will tell us. So if you're MRD negative at 2 years, you still benefit from receiving Len maintenance. At 3 years, it's a little less clear. At 4 years, it's definitely less clear. And 5 years, probably no. The numbers are small, so you have to take that into account. But in contrast, if you look at the lower row, you will see that if someone remains MRD positive, then perhaps they do. It looks as if they do continue to benefit from Len maintenance, which might argue against the point made earlier on this morning when we were talking about MRD. So if somebody remains MRD positive, maybe they need to change treatment. But there are nuances around genetic risk, which I think we haven't got time to look at today. So what else is new in maintenance, and what should we look forward to? Len maintenance until progression, I think, will be a thing of the past very soon. There are CD38 antibodies. I've already talked about the Cassiopeia study, but in RADAR, we're looking at isatuximab as a single agent. Lenalidomide plus a proteasome inhibitor, like with ixazomib or carfilzomib in the Forte study, ixazomib in the fitness study, and the benefit of adding a proteasome inhibitor is perhaps in high-risk disease. And lenalidomide plus a CD38 antibody, like in the Pasea study. And in RADAR, we have that for patients who are high risk, either MRD positive or genetic high risk. So I'm going to finish off with just talking a little bit about the translational outputs from RADAR. If we really want to personalize therapy for myeloma patients, we need to understand disease and host biology. We need to get to grips with the molecular and population basis for heterogeneity. And by population, I mean ethnicity. And we also need to understand the effects of our therapies on disease and host features, which is not trivial. And so we need to run studies that are translationally rich so we can design better studies based on disease biology and based on what we learn. So in the RADAR trial, one of the key aims is to genomically characterize our patients so that we can understand the interaction of genomic features with outcomes on our different pathways of treatment. And this is data from the lab, and I can't claim any credit for this, but it's done with the working with Sarah Gooding in Oxford, Eileen Boyle, Amata, and Ines in our myeloma lab, and this shows targeted sequencing. You saw that panel earlier on, which was put up, I think, by Angela, the targeted sequencing panel that's being used in Oxford in the NHS lab. This is the same panel, and this was the initial results on 169 page samples looking at mutations in the top 20 myeloma driver genes. And out of these 169 samples, 85% had mutations. And you can see we picked up TP53 mutations in about 8%, which is probably as expected. And some of you will know that TP53 mutation is now one of the features that is included in the new high-risk score, which I think we're still waiting to be published. So another thing we've been able to do in the RADAR study, you've heard so much about how outcomes are different between MRD negative and positive patients, how we should adapt treatment. Well, what if we could predict which patients are going to achieve a deep MRD negative response and which ones won't? So this was some data that was presented by Dipal Mehta, our clinical research fellow in RADAR at the time at the IMS meeting in Rio last year. And what he did was he looked at the immune profile of people of standard risk, mainly standard risk, RADAR participants at baseline. So we carry out a basic immune profile on patients on their baseline bone marrow before they start treatment. And then we look and see if any one of these particular T-cell subsets associate with the MRD status post-transplant, so negative in blue or positive in red. And you see here, this cuts a long story short and a lot of analyses that the people who remain MRD positive and higher levels of CD8, EMRA cells, so terminally differentiated cells, and also effector memory CD8 terminally differentiated cells. So perhaps it's a bit of a chicken and egg. You don't know whether it's the disease driving the immune compartment or vice versa, but as an immune marker of probability of not achieving MRD negative response, it seems quite reproducible. And we are not the first. The Spanish lab have also published fairly similar findings. So I was going to show you some stuff on isatuximab. So we were able to look and compare the patients who received isatuximab versus those who didn't in the post-ASCT consolidation arms. And here you see the gating for the T cells, so naive T cells and up in that quadrant, and effector T cells down here. And to cut a long story short, in the CD4 compartment, what isatuximab does is it increases effector T cells, but it doesn't reduce the naive subsets, quite unlike many other differentiation processes in which if you get effectors go up, the naives go down. And finally, is also an important effect of the CD38 antibodies on NK cell subsets, because that's how they work. They work mainly by ADCC. And here again, there is preferential loss of the mature, late differentiated NK cell subsets, but preservation of the of more progenitor, less differentiated cells. And we're still trying to work through that. And we will be able to correlate that with the conversion from MRD positive to MRD negative in this patient's group. So is the future immunotherapy? I just have the one slide. Some of you who are at ASH who will have seen Mark Raab present the study. So this is one of the first studies to ask the question, can we, instead of our 4-drug, 3-drug induction regimen, can we use a bispecific antibody as a single agent? If we could, and we could do it effectively and safely, there are plenty of advantages. We still see a lot of our patients hobbling around with peripheral neuropathy from the Velcade and the thalidomide. So he only had a few patients, outcome of a few patients to show, but the MRD and the CR rate were very high, around about 80 to 90%. I haven't got that to show you right now. But this is the start, I think, of a series of studies, and not only with bispecific antibodies, with the ADCs like belantamab. So I don't think things are staying still, and that's been alluded to already in the frontline setting. So in summary, we have highly effective induction regimens which extend disease-free and overall survival, but we still need to do better. We need to address the disease heterogeneity and personalized therapy. There are specific subgroups for whom outcomes can be improved, and we need to continue to scrutinize the benefit of ASCT. If we don't do it, others will do it. And treating until progression reflects an unenlightened approach. have we asked our patients? I haven't had a chance to talk about that. So we need to carry out careful translational studies alongside our clinical trials to truly advance treatment and improve outcomes. And I just want to acknowledge the whole of all my clinical colleagues without whom I wouldn't be here today, and also the lab who did many of the studies, the data I showed you. Thank you.
Thank you, Kwee. Shall we do the questions at the end?
At the end,
we are running slightly short of time. May I